This video will cover Advanced Cardiac Life Support, or ACLS, and Basic Cardiac Life Support, or BCLS. CPR stands for cardio, meaning heart, pulmonary, meaning lungs, and resuscitation, meaning to recover. CPR is a series of well-defined steps to revive a collapsed patient, delivering oxygen to the heart and brain. The goal is to restore native circulation and ventilation, preventing irreversible brain damage from anoxia. CPR is indicated in cases of cardiac arrest, respiratory arrest, or a combination of both. Diagnosis is confirmed by loss of consciousness, loss of central pulsations, and apnea. Diagnosing cardiac arrest through blood pressure measurement, pulse checks on peripheral arteries, and auscultation of cardiac tones can lead to loss of valuable time. The types of cardiac arrest include asystole, ventricular fibrillation, pulseless ventricular tachycardia, and pulseless electrical activity. Causes of cardiac arrest are often remembered by the 6 H's and 4 T's. The 6 H's include hypoxia, hypotension, hypothermia, hypoglycemia, acidosis, and hypokalemia. The 4 T's that cause cardiac arrest are cardiac tamponade, tension pneumothorax, thromboembolism, and toxicity, such as drug overdose. The stages of CPR include Basic Cardiac Life Support, or BCLS, and Advanced Cardiac Life Support, or ACLS. BCLS is life support without special equipment. ACLS uses advanced techniques and special equipment, typically in a hospital setting. A typical CPR team consists of a team leader, a person for cardiac compression, one for airway management, one for drug administration, a runner, and a documentation person. During cardiac arrest, the team leader assigns roles: airway management and ventilation, chest compressions, IV drug administration, defibrillation, and timing and documentation. The airway manager and chest compressor may switch roles to prevent fatigue. The team leader uses the 2-minute compression periods to plan, give orders, and address reversible causes of arrest. BCLS starts with the 3 S's. Ensure your safety, check for responsiveness by gently shaking and shout for help. Then, check for carotid pulsations for 10 seconds. Apnea is confirmed by looking for chest movement, listening for breath sounds, and feeling for airflow from the nose for at least 10 seconds. The chain of survival has 4 cornerstones: early recognition and call for help, early CPR with minimal interruptions, early defibrillation, and post-resuscitation care. BCLS follows the ABC sequence: airway, breathing, and circulation. The human brain cannot survive more than 3 minutes without circulation, so chest compressions must start immediately if central pulsations are absent. Loss of consciousness can lead to airway obstruction from the tongue falling back. Basic techniques for airway patency include the head tilt, chin lift, and jaw thrust. A finger sweep can remove a foreign body in unconscious patients, but is not advised if the patient is conscious or convulsing. The Heimlich maneuver is used if the patient is conscious or the foreign body cannot be removed by finger sweep. In infants, this is done with back blows and chest thrusts. Breathing methods include mouth to nose, and mouth to mouth and nose for infants. Supplemental 100% oxygen should be used as soon as possible. Successful breathing delivers 800 to 1200 milliliters of tidal volume at 10 to 12 breaths per minute in adults. The human brain cannot survive more than 3 minutes without circulation, making immediate chest compressions necessary for any patient lacking central pulsations. For chest compressions, place the patient on a hard surface. The hands are placed on the lower half of the sternum, 2 fingers above the xiphoid process. Depress the sternum, 4 to 5 centimeters in adults. Compressions must be performed at 100 to 120 per minute. The ratio of compressions to ventilation is 30 to 2 for a single rescuer. With 2 rescuers, compressions should not be interrupted for ventilation. Complications of chest compressions include fractured ribs, pneumothorax, sternal fracture, and injury to abdominal viscera. These are avoidable with correct technique. Restoration is assessed by pupil contraction, improved skin color, free movement of the chest wall, swallowing attempts, and struggling movements. ALS components include circulation by cardiac massage, airway management with equipment, breathing with advanced techniques, defibrillation by manual defibrillator, and drugs. A face mask is an easy airway option that does not require highly skilled personnel. However, it may cause stomach inflation and does not protect against aspiration. The oropharyngeal or Guedel airway is easy to use but does not protect against aspiration and is poorly tolerated by conscious patients due to the gag reflex. The laryngeal mask airway, or LMA, is easy and does not require highly skilled personnel. Disadvantages include stomach inflation and lack of protection against aspiration. An endotracheal tube ensures proper lung ventilation, prevents gastric inflation, and protects against aspiration. The disadvantage is that it requires insertion by highly skilled personnel. The combitube is an airway device that is easy to use and does not require highly skilled personnel. Cricothyrotomy, or a surgical airway, is used for difficult endotracheal intubation. It can be performed using a specialized set or a large-bore IV cannula, which requires a high-pressure source for ventilation. A self-inflating resuscitation bag, or AMBU bag, gives 21% oxygen with room air. With a source of oxygen, it gives 45% oxygen, and with a reservoir bag, up to 85% oxygen. A mechanical ventilator is also an option. Circulation in ACLS involves chest compressions, IV access, drugs, and defibrillation. The adequacy of chest compressions is assessed through capnography, with successful CPR indicated by expired CO2 greater than 20 millimeters of mercury. Compressions must continue for 2 minutes before reassessing cardiac rhythm. Golden rules for CPR include ensuring high-quality chest compressions, planning actions before interruptions, minimizing interruptions, and early defibrillation for shockable rhythms. A pre-existing central venous line is ideal for IV access. Peripheral IV lines are common, but drug administration must be followed by a 20 milliliter fluid bolus and limb elevation to reach central circulation. Intraosseous access is an alternative. For defibrillation, one paddle is placed in the right infraclavicular region and the other in the left 5th to 6th intercostal space. Biphasic shocks for VT and VF are 120 to 200 joules, and monophasic are 200 to 360 joules. To ensure proper electrical transmission and prevent skin burns, conducting gel must be on the paddles. Clear the bed before shock to prevent electrocution. Hold paddles firmly and continue compressions for 2 minutes after defibrillation. Adrenaline is given as a vasopressor, 1 milligram IV every 4 minutes or alternating cycles. It's given immediately for non-shockable rhythms, and after the 3rd shock for VF or VT. Once given, always continue adrenaline. Amiodarone, 300 milligrams IV bolus, is used for shockable rhythms after the 3rd shock. Lidocaine is an alternative. Magnesium, 2 grams IV, is used for VF or VT with hypomagnesemia or digoxin toxicity. Vasopressin is administered as a 40 international unit single dose once. Calcium is indicated for P caused by hyperkalemia, hypocalcemia, hypermagnesemia, or calcium channel blocker overdose. Do not give calcium and sodium bicarbonate simultaneously via the same route. Infuse IV fluids rapidly if hypovolemia is suspected, using normal saline or Ringer's solution. Avoid dextrose unless there is documented hypoglycemia, as it can worsen neurological outcomes after cardiac arrest. Fibrinolytic therapy is considered for cardiac arrest caused by proven or suspected acute pulmonary embolism. If used, consider performing CPR for at least 60 to 90 minutes before terminating resuscitation attempts. Routine use of atropine in PNA systole is not beneficial. It is indicated for sinus bradycardia, or AV block, causing hemodynamic instability. The dose is 0.5 milligrams IV, repeated up to a maximum of 3 milligrams. Sodium bicarbonate is used for severe metabolic acidosis, life-threatening hyperkalemia, or tricyclic antidepressant overdose. Avoid routine use due to complications like increased CO2 load, impaired myocardial contractility, and hypernatremia.